Hi everyone, time for Wisdom Wednesday. As you can see, back in the office, and we're going to continue on our journey in looking at Alzheimer's disease and sort of continuing with our peeling back the layers to really see if we can discover root cause and then address this particular issue from a different direction. As I tell folks, I have a lot of longevity in my family, and I just don't want to outlive my brain, and I want to keep my brain as in good a shape as possible. And we know that the changes that we see with Alzheimer's disease start 20, 30 years before we ever see any real cognitive decline or even mild cognitive decline. So with that in mind, we have to really begin to look at this from a different perspective. And we're seeing that when you're looking at brains of people who've died of Alzheimer's disease, you see this associated sort of fundamental abnormalities in insulin and insulin growth factor signaling mechanisms that are really highly correlated with the disease development and the progression of the structural, mechanical, molecular, and biochemical lesions that occur with dementia. This phenomenon, which many are calling type 3 diabetes, this model really links many of these characteristics from a molecular and pathologic features, and seeing the reduced expression of insulin and insulin growth factor and their receptors and their signaling, these genes that are important with insulin and insulin growth factor. These findings of this pronounced insulin IGF-1, if you will, deficiency and resistance develop really early in the course of Alzheimer's disease. And as I said, oftentimes this is occurring 20 to 30 years prior to the diagnosis. So we have to look at this early. We cannot wait for a patient to develop and be quote unquote diabetic, meet all criteria for that, because it's a progression. There is not one moment you're normal and the next minute you're a diabetic. There is a long progression, and that's why we really look early on to start to see, are we seeing those triglycerides starting to go up? Are we seeing more visceral fat, that internal fat start to develop, which makes us much more insulin resistant? Are we seeing hemoglobin A1Cs go up, fasting insulins go up, and that fasting insulin and blood sugar start to change? And we want to turn that around early. We don't want to watch that progression and wait finally to make a diagnosis and then go, oh, okay, now let's begin metformin. Let's look at the GLP-1 agonist that we now have available to us. Let's wait until you really get that full diagnosis. We've got to start earlier. And it's this progression of these signaling abnormalities which really leads to that severity of neurodecline, and we were trying to avoid that. This form of diabetes selectively affects the brain. So it's that insulin and IGF signaling specifically in the brain where we see a deficiency, because the brain has we are so insulin resistant that you need more and more and more. So it's really a deficiency over time that leads to these changes that are so worrisome. It's not just the end result of this diabetes or the insulin resistance themselves. It's accompanied with significant inflammatory changes. These cytokines that are very inflammatory, these mediators that increase oxidative stress. We see DNA damage, we see mitochondrial dysfunction, and we've talked a lot about those things with the aging issue that we see over time and the hallmarks of aging. These are many of those hallmarks of aging. So we need to, again, address this earlier so that we can eliminate this insulin resistance and decline that we see. So what do we do to treat insulin resistance when we see it? I mean, we just, unfortunately, we wait today. As you see, most physicians today will wait until you really are diabetic before beginning to institute treatment. And we have to start earlier. What we know is that we don't want to wait for the house to burn down before we put out the fire. We've got to start earlier. So by doing that, we have to address this visceral fat, these high triglycerides, and we must do it from a nutritional standpoint, but we also have some other tools now. We've got this semaglutide, but really what we see is that these GLP-1 agonists, which are great, have a great impact, but there is actually GLP-1 activity that we see with estradiol. Estradiol is very effective and can increase GLP-1 activity on its own by affecting the alpha cells in the pancreas and the L cells in the gut. So it's amazing that we have a tool that actually can reduce visceral fat. It's very helpful to reduce the incidence of diabetes. We see that across the board, women on hormone replacement therapy with using estradiol have a significantly reduced incidence of Alzheimer's disease, but also diabetes, of course. And it's the control of this glucose homeostasis that depends on this coordinated secretion of insulin and insulin growth factor from the beta cells of the pancreas, but then this GLP-1 is from the alpha cells of the pancreas, a different set of cells in the pancreas, but also is important in the gut and in the lining of the intestines in cells called L cells. They increase this GLP-1 type activity and agonist as well. So it's this effect that estradiol can help prevent the occurrences of both this visceral fat formation. It reduces our incidence of insulin resistance and makes us much more glucose tolerant. And these therapies have been shown to reduce type 2 diabetes in postmenopausal women, and it increases GLP-1 response by 20%. So we see that estradiol in and of itself has the ability from just the aspect of prevention. And that's where we really want to begin to focus in. So we've looked at one aspect today. We've talked about the semaglutide in the past. Now we're seeing this direct correlation of what estradiol does. And we know estradiol does so many other things, but specifically in this arena, estradiol is exceedingly important, not just for women, but for men as well. And in many hormone replacement type treatments with men, a lot of providers are trying to reduce estradiol in men. And this is not something that we want to see because it has such great impact from a mechanistic standpoint in helping us with insulin resistance and IGF signaling. So hopefully that's not too sciencey for you. I think you can understand that there is benefit to the preventive, trying to address this from a preventive standpoint, trying to address this from an earlier standpoint, not waiting for disease to occur. And as we continue in this journey, I'll be walking through many other things that hopefully will give us a little more insight over time in how we can really work toward trying to absolutely prevent Alzheimer's disease through early interventions. Hope you all have a great week, and we'll talk again next week.